The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, this is Eric back with you with the FlightBridgeED Podcast. I've got a very special guest today. I've got a good buddy of mine, a colleague and clinical manager for Air Methods, Kelly Miller, is here with us today, and he's got a real extensive background in cardiology, loves balloon pump therapy, and we've talked a lot over the last probably 12 months about trying to get together and jump on a podcast and kind of do a questions and answers. We're going to do this very similarly to how we did it with Alan Wolf, where we talked about LVADs. Got a huge response from that. And I know balloon pump therapy, when I teach the review classes and I teach it around the country, that's always a very confusing topic for a lot of people. And so I think it's fitting that we kind of jump into a all no holds bar question and answer period. So I just want to welcome Kelly.
Thanks, Eric. I appreciate it. Appreciate you having me on. As you mentioned, spent a lot of time in cardiovascular unit through my nursing career, recovering open heart patients, dealing with balloon pump patients. So frequently on our unit, had balloon pump patients in and dealt with them, dealt with several of the complications that arise through balloon pump therapy, and then been flying with Air Methods since 2007. So was at a base where that we frequently saw balloon pump patients. So got to deal with several of the transports of those patients and some of the complications that comes with that. So it's gave me an appreciation for balloon pump therapy and forced me to learn more about it throughout my career.
Yeah, I can say, just working alongside Kelly, he's kind of my go-to person. I've actually called him and he can say, testify to this. I've called him a few times from review classes somewhere in the United States where somebody's given me a question that I had no clue about. Actually, I remember calling you about a early deflation, and if you remember, you said that it was atrial regurg that was causing that plateau. And so I actually, for those of you that have taken the review class, you've probably heard of the name because I always reference Kelly, and I reference a few things he's taught me. So again, very, very happy that you're able to join us tonight. So what we're going to do, folks, is we're going to just kind of do a questions and answers. I'm going to kind of stimulate the conversation based on different topics, and we're just going to kind of go through everything that we can really apply to the transport environment. And that's the cool thing about Kelly, is that he's got both a ICU background and a HIMSS background, pre-hospital transport background. And so it really does apply to our listeners. So why don't we start off and just kind of talk about, what are your thoughts on how many bases are balloon pump prepared, or do you feel like balloon pump bases should be every base, or do you think they should be a select number of bases?
Well, there's mixed feelings on that out there. If you would ask me this question probably, early on in my career, 7-8 years ago, I would definitely say that it needed to be more limited. But now with advances in balloon pumps and the limited amount of intervention and timing and things like that, they've really reduced the complications that we would see in flight to deal with. So I think it has become a easier management as far as the actual management of the device. The problem you get into is the mismanagement of the patients by the crews based on not understanding what the device is doing. And so when they get into other therapies, different inotropic therapies and vasoactive medications, and dealing with the patient, understanding how it works, and sometimes they end up fighting against the pump itself. So to answer your question, I think that, even though it's a low volume device, I think crews can definitely be trained to handle it and take care of it. But it's more so understanding how it works, how to manage those patients properly, than it is understanding, timing of a balloon pump or something like that in the current time and with the current models that we deal with in balloon pumps.
Yeah, I would agree. I mean, I think, it's probably specific to the area based on the hospitals and how many balloon pumps are being put in. Obviously in our area, we have 3 balloon pump bases that do balloon pumps, but, I think you're correct in that it's not so much now running the balloon pump. It's not so much about timing because, you're going to talk about that here in a little bit, that it's pretty self-sufficient, but it's more about understanding the critical thinking and the overall pathophysiology going on. And I think you hit that right on the head. So hopefully we'll be able to answer some of those questions and hit on some of those things. As far as history goes, how long has balloon pumps been around? I mean, is this a fairly new technology or has it been around quite a while?
No, balloon pump therapy around the 1950s is when they really discovered of how the coronaries were fed, and that they were fed during diastole versus during systole. And balloon pump therapy started in the 1960s. They initially started out experimenting actually withdrawing blood from the aorta, then injecting it back in. So during systole, right before systole, during diastole, they would retract blood from the aorta, and then when systole happened, it would cause a void in the aorta, relaxing, causing ease of workload on the heart, and allowing the heart and the cardiac output to increase by that void. And they done that by actually retracting blood out. Then they started experimenting with latex balloons later on in the 60s, and that's kind of where balloon pump therapy got started.
Okay, so kind of shed some light on why would a physician put a balloon pump in versus, let's say, the new Impella devices? What's the let's kind of hit on that, and then we'll talk about the purpose of the balloon pump.
There's a ton of controversy right now. Of course, Impella seems to be the new kid on the block. So the studies are right now currently, a lot of them are leaning toward proving how much better of function the Impella has than older technologies, older cardiac assist devices such as the balloon pump. So you've got a lot of studies that are going back and forth. And I know McKay, for example, has a lot of data showing not so much that one is better than the other, but showing that, hey, each one has its area which it can help and how it can benefit. I'm no real specialist into really taking down and dissecting the studies apart to see which one's better. But I know from taking care of patients on a balloon pump, I've seen the difference it makes in a patient pre-balloon pump therapy and counterpulsation therapy and post-counterpulsation therapy. And I can tell you that hemodynamically and perfusion-wise, it makes a difference in your patients. I've seen patients that, to put a patient in standby just to take and auscultate breath sounds would cause arrhythmias. And loading, unloading a patient would cause arrhythmias and cause patients just to rapidly decompensate. Decreasing 1 to 2 to check and see about your timing and so forth at bedside would cause, patients to go into bigeminy and trigeminy and issues. So do I know and have I witnessed that balloon pump therapy does improve perfusion and improve patients' overall condition when they are in need of therapy such as this? So in the cases it fits for, yes, it does help the patients. And I've witnessed those patients and seen the turnaround they have when you put that mechanical therapy into place.
Yeah, I think, and it may just be, I just haven't gotten lucky. It seemed like, 5 or 6 years ago, Impellas were, I was seeing Impella devices. I've never transported one, but I'd see them and, you'd hear a lot about them. We were doing a lot of education and I just haven't seen the continuation of that. It's back to all balloon pump therapy. And so I just was curious on what you're seeing and what your thoughts are. So as far as what's the overall purpose of the balloon pump, what are the different kind of pathophysiologies that a cardiologist is going to place a balloon pump?
Yeah. So what a balloon pump ultimately is going to do is increase your mean arterial pressure and do it mechanically. So many of the things that we could do with inotropic therapy and so forth, but that increased workloads and increase the sympathetic drive of the patient, we're able to do mechanically. So it rests the patient while doing these same things. So what does it do in a nutshell? It does a couple of things. Increases your cardiac output. During deflation, you will see increase in cardiac output by typically most of the things you see say around 40% increase in your cardiac output. Also during diastole, we know that the coronaries are perfused during diastole, and by augmenting during diastole, we significantly improve the perfusion of the coronary arteries. Also, by increasing the mean arterial pressure, we increase perfusion throughout. And one of the big things that they really push now when they talk about balloon pump therapy is tissue perfusion. So the increase in the mean tissue perfusion. So all tissues are perfused, because that's the big counter reactivity of some of your inotropic medicines is the actual tissue, the decrease in tissue perfusion.
Sure. Yeah, and I know, neosynephrine is one of those ones where it clamps down so hard that you might have a loss there. Right? So that's really cool. When we look at contraindications, obviously contraindications, and when we talk about contraindications, a lot of times it's being applied to these advanced certification exams, and we're not going to be placing these balloon pumps. These balloon pumps are already going to be placed, and I would probably argue that the cardiologists have done their due diligence and identified contraindications. But what are some contraindications that would stop a physician from placing a balloon pump?
Yeah, so contraindications and problems that's going to cause issues for the patient would be a lot of your aortic disease. So calcification of the aorta, aortic stenosis, aortic aneurysms, also aortic valve disease. All those can be complications. And then the other thing you get into is peripheral vascular disease, because limb ischemia is one thing you always watch for. And balloon pump therapy, as far as the complications of limb ischemia, has really, really went down over the years as the catheters have got smaller and smaller and different techniques have went into place. But still yet with that, one of the contraindications, you would not want to put one in with someone with severe peripheral vascular disease because of the risk of limb ischemia.
So with these patients having these contraindications and they have a stunned left ventricle, or they have no ejection fraction, they have a failed cath, whatever it may be, what's the alternative?
Yeah, in that case, you get into some severe complications, because you start trying to figure out what you can and can't do, and you're pretty limited, because your therapies and some of your other therapies you talk about, they all involve, something going through the aorta, and so you get into an aorta that is severely calcified, or you get into aortic valve disease, things like that, can really be complications on most of the devices you use. I have seen balloon pumps placed in patients with, for instance, a abdominal aortic aneurysm as a life or death thing.
Yeah. So
you would put it in, and what they would do is just dial back the augmentation so it would not be as aggressive. I don't know that would be anything recommended, and obviously it's a contraindication by the manufacturers, but I have seen it done in patients, especially patients to come off pump and things like that, when they just had no other means of the patient surviving.
Yeah, I mean, I guess sometimes it's risk versus reward, and that's why those physicians have MD behind their name. They can kind of make those decisions and talk to the family, and hopefully, sometimes that's all you can do. When we talk about, you said augmentation, so let's jump into that. Can you explain to the listeners what augmentation is, what full augmentation is, and what we're talking about there?
Yeah. So the way balloon pump therapy works is the actual balloon sits in the aorta, and during diastole is when the balloon inflates. And so during that inflation, what it does is displace the blood volume, causing an increased mean arterial pressure. So it increases perfusion throughout. And with that increased mean, your diastolic augmentation in most cases becomes, and the way you would think about it would be almost like your new systolic. And it's in the means that it's your new high pressure.
Okay.
So if a lot of these patients, if you put a cuff pressure on, an automated cuff pressure, sometimes they will read that as your systolic pressure because that is your new high pressure. So you may have a systolic of 90, but now during during diastole, we may have a diastolic augmented pressure of 130 or 120. So it's your new high perfusing pressure. So that is your augmentation. And that's the main pressure that we're monitoring. When you have these patients, that augmented pressure, if you're treating patients based on maintaining a systolic of 90, if we have a Levophed on, for example, and we're titrating that Levophed for a systolic of 90, when we put a balloon pump in, then we're going to be looking more at either our mean or we're going to be looking at our augmented pressure. Because our augmented pressure, which is our new high pressure or high perfusion pressure, is going to be 10, 20, sometimes 30 points above that systolic pressure. So we no longer need to titrate to that, and we can actually work against the balloon pump if we start titrating these vasoactive drugs and causing our systemic vascular resistance to clamp down. And so it's one of the things that's very important, as I mentioned earlier, is the treatment and understanding how the balloon pump works and understanding that augmentation and that augmented pressure, because that is what you need to treat the patient around, is that augmented pressure, not the systolic pressure.
Well, I think that's important that you talk about, increasing the vascular resistance by utilizing medications and kind of fighting against that. And I want to hit on that later on in this podcast, and we'll specifically talk about those patients that have an SVR of 2200 and they're mildly hypotensive, that are in cardiogenic shock. And, everything that we're taught, you don't want to give a medication that's going to dilate them out. But, so I want you to kind of touch base on that. We'll kind of hit that down here on the later part of the podcast. But I do think that that's an important thing to hit on. I know we've talked about this quite a bit, and you taught me this, that balloon volume and the augmentation volume. Can you talk about the differences now in the size of the balloons and how most patients now are getting a 40 to 50 mil balloon, and the importance of that placement and that placement confirmation? Yeah,
so the main manufacturer that we deal with in this area, and that I've dealt with in my career, is McKay now, used to be Datascope. And with those, they've kind of progressed and got more aggressive in their balloon size. And balloon size goes all the way down in pediatric. They do pediatrics like 2.5 cc, and then it goes up. Typical adult sizes are 30, 40, 50 cc's. In my early career, you never saw anybody above a 40 much. It was, it'd have to be Shaquille O'Neal to put a 50 cc balloon in. Now they've come out and they've revised the balloons a little bit and done some studies, and they've got more aggressive with them, so they get more displacement, more benefit for the patients. And they're taking the larger 50 cc balloons and putting them in your more average size patients. And of course, the main thing is making sure the placement is done correctly. But once they have that, they get more displacement, and they can be more aggressive with all those numbers we talked about as far as benefits. How much it increases your cardiac output, how much it decreases your vascular resistance, your afterload. So all that stuff can benefit more by going to this next size up balloon, and these mega balloons that they're putting in now is the way they refer to them. But it's made a big difference in therapies and in the differences in the numbers we get. And we'll talk later on about diastolic dip and things, but and augmented pressures. But the differences we used to look at, they're now doubling those almost in some of the cases of these mega balloons, they call.
So with the increase in size, placement is important, and confirmation is important. So can you talk about, when you go and pick up a patient, whether you're in an ICU, you're in a cath lab, the importance of verifying placement with a chest x-ray, looking at your urine output, making sure you have a Foley, those things, your pulses, kind of talk about that.
Yeah, so when they place this balloon, the balloon goes up, as we mentioned, into the aorta, and the tip of it sits just below the left subclavian. So with that, if it was to migrate up or is up too far, then you're going to lose your left radial pulse. And so that's something you're always watching for, is that left radial, and keeping a close eye on. Also, the bottom of the balloon, and especially you get into these mega balloons, sits just above the renals. So if it migrates down, then you have worry about poor renal perfusion, decreased renal perfusion. So you're always watching your urine output. So that's two things that you're watching as far as the migration of the balloon. The tip of the balloon, you'll be able to see on chest x-ray fairly easy. And one thing you should look for is to make sure that it's not in the arch. You shouldn't see it starting to make the bend of the aortic arch because that would obviously be up too far. And then placement-wise, it typically sits between somewhere in the second or third intercostal space.
Okay. All right. So when we think about augmentation, we've talked about balloon size. Let's talk about the gas that's utilized, why we utilize helium over standard oxygen or, let's say, nitrogen, something like that. Why is helium so beneficial in this setting?
So the main reason that they use helium in this setting, and there's been a lot of stuff out there about the different things if you have a balloon rupture, and some things I'd heard was it's more so related to the balloon rupture, and it's more easily absorbed in the blood and so forth to not cause embolisms. But what you'll see if you do research on when balloons have ruptured, that most of these patients do have embolisms. But it is a very, 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 very rare complication. More so the reason they use helium is because the low molecular weight, and when the balloon pump is working to inflate, deflate the balloon, it needs to move that quickly. And helium has a lower molecular weight than just standard air or oxygen, so it's able to move that in and out a lot quicker than it would with just standard air or oxygen, either one. So that's the reason they use helium, is because of its low molecular weight and the speed that they can get it in and out of the balloon quickly.
Yeah, and I think that's an important concept to remember. You know, we talk about this a lot in the different courses that we teach about the density and how slow nitrogen actually diffuses. You know, and even compared to oxygen, and how helium is utilized in respiratory patients, heliox, and the importance of how tiny that molecule is. So it's the same kind of concept. So I think that's really, really cool. So we already talked about afterload reduction. We talked about, the purpose of the balloon pump is to perfuse the coronary arteries during diastole and reduce afterload, reduce the workload of the heart, reduce O2 consumption. Can you explain, though, you were talking about that void and how that void aids in reducing afterload. Can you kind of talk about the reason why that happens?
Yeah, the way when the balloon deflates and that void that's caused in the aorta almost causes, like you would think of a suction effect on the ventricle to pull the blood out. Because if you imagine, if you're getting ready to walk through a doorway, and that doorway, if you go to it and there's resistance, versus if you go to it and someone's on the other side just pulling it open, if the wind sucks that door open as you're walking out, how much easier it is to go out. And that's the best way I can summarize how the left ventricle is able to work when that balloon deflates suddenly right before you have contraction of that left ventricle and that aortic valve opens. So when that heart contracts and the left ventricle contracts, there is nothing there as far as resistance-wise for it to go against. There is actually, it's almost a negative effect for it to go against because it's got such a large void there. So the workload of that left ventricle is, it takes it to nothing because there's just no resistance there for it to pump again. It's a pull almost coming from the deflation and the void left where this balloon is deflated.
Yeah, that's that's always something hard to explain, but I think it's a really ingenious thing, and it's kind of funny how you talked about the initial early on how this was invented, how they they kind of discovered that. I think we discovered a lot of things by accident. So when we talk about clinical signs of improvement, so you have a patient, they've placed a balloon pump, we've loaded them in the helicopter or the back of an ambulance. What are some things that you're looking for as far as clinical signs of improvement? What are some things that our providers should be kind of focusing in on?
So some of the things I think you would look at, of course, number one is a increased perfusion just throughout the body. So signs and symptom wise of the patient, I would look at increase in mean arterial pressure, being able to back off if you're on inotropic medications or on vasoactive medications, being able to back off those and decrease those. Also, would look at less signs and symptoms of ischemia. So if they were having ischemia before, due to this increased perfusion of the coronaries, you would hopefully see a decrease in any type of ischemia or signs and symptoms of it, such as arrhythmias. Like I talked earlier, the patient that would go in and out of bigeminy every time you would stop therapy. So those types of signs and symptoms of ischemia, I would hope would decrease along with a increase in perfusion.
All right, cool. Let's kind of look at really quickly a few transport considerations, just some terminology. Then we'll get into timing and start kind of talking about your different pressures that you're looking at. Unassisted systolic versus assisted systolic, and what you're looking at as far as documentation goes. But what does balloon dependent mean to you?
So balloon dependent is very similar to that patient that I talked about earlier, that you see both hemodynamic and assessment changes anytime that therapy is stopped with that balloon. Those patients, that's not every patient you get on a balloon pump by far, but those patients are out there. And you will see those patients that have the arrhythmias, have the ischemic changes, have the hemodynamic changes rapidly when you either pause therapy or have to stop therapy. So it is very important when you go into these patients, and one of the biggest processes of transport is the changeover process, and then the loading and unloading. And during both those times, limiting the amount of time that they are without therapy is very important. And that takes a strategy when you go in to do it, with the different triggers that we can use. And we'll talk about that later on. But the fact that we can use arterial and EKG trigger during this time period, we can be strategic and not really have any time during the changeover at bedside, if we do it at bedside, that we have a stop in therapy, except for just unplugging and plugging the actual balloon tubing between the pumps. So a very short time in therapy stoppage. There shouldn't be a patient changed over where that you stop them on one pump and do a complete hookup on another pump and then start therapy back. The time period should be very, very minimal from unplugging and plugging and hitting the start button, and that should be it. So changeover, if you go in with a plan and you go in strategically doing your changeover and your swap, it should be very limited time off of the balloon, so you can easily change over a balloon dependent patient and still swap them over to your transport pump if that's what you're doing.
Well, I think those are really good points. Are there things that providers should clue in on or ask that are going to kind of get them in that mindset that this is a balloon dependent patient? Or would you recommend just kind of always thinking that every patient is a balloon dependent patient and treating them as such and just limiting that time?
Yeah, I think every patient that has the balloon pump therapy in, there's obviously been a reason that cardiologists has felt like to put it in, and it is not just on a whim that most cardiologists will put these in. So I think you should treat every patient that way. But before you start pausing a balloon to listen to lung sounds, or you go in and just flop one over to 1 to 2 to check your timing or anything like that, I think you should always talk to the nurse there at bedside or whomever you're getting the patient from, and ask, is this patient handled 1 to 2 okay for me to check their timing and to check their assisted versus unassisted? Has this patient handled, standby mode long enough for me to listen to lung sounds and get a good listen to the heart? Is that okay? and check with that before you do it, because the least thing you want to do is go in and flip somebody into standby and then find out that they've been having ventricular arrhythmias every time they do that, and you're standing there looking like a fool, and the patient suffers from it. So always ask questions, because those patients are out there.
Well, and I really think, kind of just thinking about this objectively, when we think about airway management, and everybody knows I love ventilators, but you have an ICU patient on a ventilator, you're not just going to, just arbitrarily take them off their ventilator and they got 15 a PEEP. You're not just going to take them off and just do whatever you want and then just decide, all right, well, now it's time to hook it up and set it up. You're going to have a strategic plan. And I think that is important. I think obviously providers that, the amount of balloon pump patients that we fly is very, very minimal in comparison to everything else. Obviously you have those bases that do more than others, but so I think it's important to, talk about these things and get a plan, like you said, and practice those things and know the capabilities of your helicopter and know the facilities you're going into. I mean, I think all those things really play into making good decisions like that.
And I think a good example of that also is you wouldn't go into a patient that's on 20 of Levofed and roller clamp it while you're changing the patient over and you're taking them to the helicopter, or you're taking them to your ambulance. You wouldn't do that, because the patient would decompensate severely during that time. And it's the same thing with this. You're going to plan accordingly with that drip, where you switch it over rapidly and there's no pause in between. And you're going to do the same with this therapy, because this is a mechanical device to increase your mean arterial pressure and perfusion, much as that's a chemical device.
All right. Well, now that you talk about chemical, what would be a chemical balloon? So we talked about a balloon-dependent patient. What's a chemical balloon?
I've heard several people compare drugs like milrinone to a chemical balloon pump, and there are chemicals out there and drugs that can assist and help do these things. But for the most case, when you have those drugs in place, they are causing your body and your heart to work harder when you do that. And they are increasing that myocardial oxygen consumption, increasing the demand. And so that's where, when we come in with a balloon pump, it's, to me, it is taking all the benefits of those type of medications and those drugs and taking away the bad parts of it, because now we're doing it mechanically. We're not doing it by increasing the workload of the heart. We're not doing it by, stimulating the sympathetic nervous system and causing the body to work harder. We're doing it by putting in a mechanical device that, while it does have its complications, they are limited, but we can do that and have the same effects as far as the patient being able to increase perfusion, being able to perfuse the heart and the coronaries significantly more, and increasing mean arterial pressures without causing the body to work harder and allowing the body to rest, while we're doing it by using a mechanical device.
Yeah, well said. I think that's great. I mean, I think there's obviously lots of medications out there that we see used all the time that are those classic inotropic medications. And, when you talk about medications like dobutamine and milurone, they have their purpose. And again, we'll talk about that in a little bit. But the balloon pump is there for a reason. And again, like you said in the very beginning of this podcast, you don't want to work against your balloon. So moving on from there, let's talk about timing. You've kind of talked about timing a few times. You've said 1-to-1, you've said to 1-to-2. So let's talk about why you would use 1-to-1, why you would use 1-to-2, the purposes for each one, specifically for transport.
Yeah. So in your ratios, you have 1-to-1 therapy, 1-to-2 therapy, and even 1-to-3 therapy. 1-to-1 is your optimal therapy, and that's going to be your goal, and that's going to give you the most benefit of the device is in 1-to-1. 1-to-2 therapy, where you're going to look at that, is your patients either that A, you're trying to wean off therapy, or B, would be a patient that is tachycardic, that while you're doing intervening to try to slow down that tachycardia, that it's not allowing the pump to work properly. So when you get a heart rate around 120 or a little higher or something like that, that might be a case where you slow down to 1-to-2 just to allow the pump properly inflate and deflate and to handle that type of rhythm and workload. Because I tell you, when you get into such as a patient with atrial fib, with RVR, and you've got a heart rate around 120, 125, 130, and you try to leave that patient in a 1-to-1, it is tough on that balloon pump to keep up and really to optimally help the patient. So that's typically when you'll see a 1-to-2. 1-to-3, the only time I ever seen that is weaning right before you pull a balloon pump, just to make sure the patient's going to tolerate it.
All right. So kind of to compare that, you have somebody in AFib, you have somebody in a tachycardic rhythm. You said that the balloon cannot fill and deflate fast enough. So kind of compare that to just a tachycardic rhythm, right? You have a patient that's got a rhythm that's 150, and their left ventricle cannot fill and clear appropriately. So that's why cardiac output is decreased. So it's the same concept, but it's just based on a mechanical issue. Okay. So as far as timing goes, we have two forms of timing. Why don't we talk about each one of those and what is our primary timing versus our secondary timing?
Your triggers that you look at, your primary trigger and your go-to trigger is always going to be your EKG. And your EKG, you trigger it off of the upstroke of your R wave, and that is going to be your primary target and trigger of the balloon pump. And then it triggers based on inflation, deflation, knowing that 2/3 of that cardiac cycle is going to be diastole. Your secondary trigger would be arterial based on your A line and looking at the diacrotic notch and looking for aortic valve closure and triggering off it. EKG is, of course, your go-to, and that should be what you try for at any point. The only point where that you're going to definitely take them out of EKG trigger is in a patient who goes into cardiac arrest. And in that patient in cardiac arrest, you want to switch them over to arterial trigger. And in the newer balloon pumps that have the auto mode, they will automatically switch back and forth. So if I'm pushing my patient down the hall and someone trips over an EKG lead and pops it off, then it's going to switch over to arterial trigger. And the same thing in changing over and swapping pumps. If I take them off EKG for a little bit to put the leads on, change the leads to my new pump, then it's going to switch over to arterial. So you can utilize that. One thing I recommend is for providers and transport, if they have a patient arrest that's got a balloon pump in, something they can easily do to switch triggers instead of having to mess with the balloon pump is if they'll just pull a lead off for the balloon pump, then it'll automatically go into arterial trigger. And when they start CPR, then it's in arterial trigger form. So that's one thing that I've seen done before and works, is just to unhook one of their leads, and then automatically it'll switch over to that trigger. That's
a really good point. I like that.
But to answer your question, those two are your primary. There's some other triggers you can time it once you get more advanced into like a manual setting. You can time it where it's hooked up with a pacer, and it only works when the pacer paces and things like that. But for our field, that's the only two triggers I think you would ever see used and you would ever want to use. You're going to have, if you get into a manual operation with these balloon pumps, you're probably going to have a perfusionist with you.
Okay. All right. So when we talk about the A line, let's talk about the difference. I get this question all the time, and I think it's very easy to mix this up. When we think about a swan and we think about the dicrotic notch, let's talk about the difference between the representation of that dicrotic notch with a swan versus that dicrotic notch with a balloon pump A line.
So the balloon with an aortic A line, you're going to get a really pristine dicrotic notch, and that's going to get you your best dicrotic notch. Most time if you looked at a radial A line, you're not going to see a very good dicrotic notch at all, and it's going to be very hard to pick that out. Still yet, with a balloon pump, if I have a balloon pump, and we'll give an example, and this is an example I've had, where the A line in the balloon pump in the groin occludes off and you no longer have it, can you put a radial A line in and use that A line and have it there as a backup? You can. the balloon will still time off of your EKG. So do you have to have an arterial waveform, a great arterial waveform? No, but that's good to have there as a backup, because if you lose that EKG, then now you're in a mess. So you want a good clear A line as much as possible. But if it does occlude off, you can use a radial, but you're going to get a really good, your most pristine diachrotic notch is going to be from your femoral A line, and that's where you're going to see your most clear diachrotic notch for your timing and to look and make sure you've got proper timing.
Well, another great point, when we think about the diachrotic notch, we always teach that it's a valve closing. So when we think about a swan, that is representative of pulmonic valve closure. When you think about that balloon pump in the A line and going up the femoral artery, that's the aortic valve closure. So a lot of times when I teach, I tell people, if you're reading a question and they ask you that question, what that diachrotic notch is representing, they need to understand what the A line is being used for.
Correct.
And so when we think about the diachrotic notch and we think about the A line, where is there other areas that a balloon pump can be placed? I mean, does it always have to be femoral, or do they place them in other areas?
All that I've ever seen is placing them femorally. There's a couple different ways they place them now. And they either use a sheath, and then sometimes they use just a cut down and do it sheathless. And that's to help with the limb ischemia, and it has helped a lot. And so more often you're seeing that approach used for the fact to decrease your limb ischemia. And they've got down your major limb ischemia to like less than 1%, I believe was the last statistic that I saw. And a lot of that's through the different smaller catheters and then also using the sheathless techniques. So that's the two ways they put them in. With the sheath, when you're going through and removing, there's always some worry there about leaving the sheath in and removing through the sheath. So putting them in sheathless, there really isn't any issues with that. So if you have someone skilled enough to do it. So once they do it, it's more beneficial for the patient.
Very, very cool. When we think about dissecting the waveform, right? So, like I said, we're going to actually put a blog. I may not have said that, and we are going to write a blog. We'll put some waveforms on the blog. But when we think about comparing the waveform, we're in 1 to 2 timing. As you said, we have to compare unassisted systolic pressure versus assisted. What are some things you're looking for on the augmented beat versus the unaugmented beat? What do we want to see? What don't we want to see?
Yeah. So when you're looking at a balloon pump arterial waveform and you're in 1 to 2, so you're going to have your unassisted systolic upstroke. Then you're going to come down to your diachrotic notch. And that diachrotic notch is where your balloon pump is going to augment. So you're going to augment the diastolic pressure following that. The end diastolic is going to be your assisted end diastolic pressure. And then your next systolic is going to be your assisted. So where you actually see the balloon augmentation, that systolic waveform that it is in the diachrotic notch of is not assisted. So a lot of people get that confused, because when you think about it, the part of the balloon pump therapy that is assisting systole is the deflation. So that lower end diastolic pressure is what helps systole. So that's what's going to help your systolic pressure and help your left ventricle to empty. So therefore, it's after that diastolic pressure is your assisted systolic pressure.
So essentially what we're saying is that you're going to have an unassisted systolic pressure. Let's say it's 120. Let's say your unassisted diastolic or end diastolic pressure is 70. You have an augmented beat. Then that next unaugmented beat is going to be your actual assisted beat, because that's after the augmentation, right? And so what you're going to have there, what you want to see is you want a reduction in afterload. So your systolic pressure needs to be lower, and your end diastolic pressure needs to be lower as well, right? And that's going to tell you that you're doing things correctly.
Yeah. So in your waveform, you're going to have your unassisted systolic pressure is going to be higher at its peak, and your number is going to be higher. So if your unassisted is 120, then I'm coming down, I'm having my diacritic notch, I have my augmentation of, we'll say, 135, and then I'm coming down, and now my end diastolic pressure, we'll say our unassisted diastolic right before that systolic of 120, we'll say it was 70, as you said. So now my assisted end diastolic pressure is probably going to be 50. So you got a significant drop there.
Yeah.
And that's what causes that suction or that negative effect on the left ventricle, that void space by the balloon deflating, and allows my left ventricle to work so much easier. The fact that it works easier, many times the systolic pressure is a little bit lower, but that doesn't matter. My assisted systolic will drop 10 points many times. But due to the fact I've got an augmented pressure of 135, I don't care that my new systolic is 100, because that's not my high perfusion pressure.
Sure. Well, I mean, I just think this is so fascinating. I love the easy concept and how it, just kind of takes over and does everything much more efficient for a sick, stunned heart. So, it's really hard on a podcast, obviously, to talk about timing errors and dissecting waveforms and things like that. But, there's a few little tricks that you've taught me regarding inflation, deflation, timing errors. So, like I said, we're going to do a blog post. We'll have all the instructions on how to identify the different timing errors. But what are your two worst timing errors, and what are some tricks if you had to fix this? And I know that balloon pumps now are automatic. They're going to have very, very few, if at all, timing issues. What are some tricks that you've learned over the years?
So to kind of touch on when you need to time and when you don't need to worry about it and so forth, the balloon pumps now typically come with an auto, a semi-auto, and sometimes a manual. Sometimes you can't even hardly get into the manual setting anymore. But with auto, there is no timing involved on our side. It is a start button and it takes off. So we hook them up and it goes. Semi-auto is where we're going to get into timing. We set the timing based on, whether we need a little earlier or later on the inflation and deflation. And then when there's arrhythmia, when there's heart rate changes, the balloon, the pump adjusts based on those. Then you can get into manual, and in manual setting, you have to adjust every time there's a rhythm change, every time there's heart rate change. So manual is typically something you will see with a perfusionist, maybe in a pediatric patient with a balloon pump in or something like that. It is really rare. And in my career and what I've done, I've never seen a patient in manual. But not to say it's not done, because there are specialty centers where it is done. So when you get into timing, and if we're in semi-auto and we have a patient that we feel like we could do better on timing and we need to look and see, then what you need to do is understand where you're going to hurt the patient and where you're not going to hurt the patient. So if you think about how the balloon works, the biggest thing you don't want to do is cause increased resistance and increased workload on the heart. And so if you think about what's going on, when are we going to do that? So when we're going to do that, if the balloon inflates too early. So if it inflates too early during systole, the left ventricle now is pumping against a wall practically, because we have this huge balloon that's inflated in the aorta, and versus decreasing our afterload, we've now put a 40 cc balloon in our afterload. So we got a problem. So that's going to significantly hurt the patient and increase the workload of the heart. And then you go, and the other one you look at that's going to significantly hurt the patient, cause problems, is late deflation. Same thing. When I go and my aortic valve opens and that ventricle is like, all right, my turn, bam, and it contracts and goes to to contract and for systole, and it's got a balloon sitting there inflated, I've just caused a mess and caused increased workload, can cause valve damage, a lot of problems can go on there. So those two are the ones that you want to stay away from. If you're going to adjust timing, that's the reason the old saying that you always start out by fiddle to the middle, because the way these timing bars are set up is if you go inflation and deflation, inflation's on the left. To go earlier, you go out. To go later, you come in. And then deflation's on the right. To go earlier, you go left. To go later, you go right. So if you take the two to the outside, you're going bad. You're going to the ways where you can hurt the patient. So if you're going to adjust timing, the saying was always to fiddle to the middle. So you would bring him toward the middle first to adjust that, because if my inflation is a little late, that's not going to hurt the patient. It's not going to give the patient the most optimal therapy. So I'm not going to help the patient as much, but it's not going to hurt the patient. And the same thing with early deflation. If I deflate a little early, I'm going to really decrease the amount of help I can give the patient, the amount of help I can give that left ventricle, but I'm not going to hurt it. And so that's the key in timing, is to make sure that you don't hurt the patient with it. And the way you're going to hurt the patient is with early inflation, late deflation, and that's where it causes increased workload on the patient.
Well, that was a really great explanation. And again, we will put these timing errors in the different waveforms on there, and hopefully that'll make more sense if this isn't something you're kind of familiar with. Kind of moving on, really quickly, there's a lot of different complications that are potential, but pick out a few that you feel are the ones that our providers really need to focus on and look at.
The things I would look for, and especially in the transport world, what you have to watch for is making sure you're going to watch your left radial pulse to make sure it doesn't migrate, the balloon doesn't migrate up. As far as displacement of migration of the balloon moving down, urine output, of course, and most of the time in the transport setting, unless you're doing long distance like fixed wing, you're really not going to keep a really close eye on that, on your urine output. But that's something you want to look at to make sure that the patient, if you went to pick this patient up, make sure that you do have good urine output. Then during flight, some things you can do. You want to watch for limb ischemia. So typically, according to what aircraft you're in, most of the time you're not going to be able to get to check distal pulses. But definitely before loading and then unloading, you want to do that to make sure there's not been any changes. The site, you can often have bleeding from the site. So keep an eye on that site. And I always try to look at it a couple of different times during the flight just to make sure I don't have bleeding or anything I need to address there. One thing and one issue I've seen happen with some of these new pumps now, and this kind of brings up the fiber optic, which we'll talk later, but if you have a fiber optic balloon, there's an A-line there, but you don't necessarily have to monitor it and use it. But I always tell our crews and recommend that our crews hook that A-line up, even if they hook it up just to their regular transport monitor, because what you don't want to happen is a stopcock get moved, a connection get unhooked on that A-line and you not know about it, because that's an arterial line and you're going to have some bleeding from that before you get down there and get to fix it. So I always recommend them monitoring it just so they can watch for complications. So that's one thing I would caution people in, because that's a common mistake I see with the new fiber optic, is totally not monitoring that A-line at all. But as far as complications, vascular complications is the biggest one that they have, I think. They can have embolies and so forth, but that's typically related to how they were inserted. If you have a complication in flight that causes an emboli, it's going to be a balloon rupture. Once again, that's very, very rare. And as far as a balloon rupture, what you're looking for there is in the actual balloon line, you would get an alarm on the pump to say, hey, you have a rapid gas loss. So in that rapid gas loss, one of the first things you want to always do is check the tubing going to the balloon pump, the balloon tubing. In that balloon tubing, if you have any blood or you have what they call like rusty flakes, which is many times how the blood draws out, then that's when you want to stop the therapy And what the manufacturer actually recommends is unplugging it and then notifying the cardiologist that it inserted the balloon. In the transport mode, that would be, of course, you would try to contact your medical director, but you definitely want to stop therapy and unplug that from the machine is what the recommendations are of the manufacturer, is to unplug that. You can also, one thing that you will see happen is patients that either you have them sitting up too far, or patients that are obese and the angle of the balloon going in causes almost like a kink. Then the gas loss alarm is based off of not how much gas is put in, if there's too much put in, but that how much is put in, that much returns. And so if the balloon puts in 30 cc's and I've got a kink because I have a patient with obesity that has a large leg, and that angle is very sharp as far as insertion angle, and because of the catheter's kinked, I'm only getting 25 cc's back, then I'm going to get a rapid gas alarm leak. So the first thing you always do with that alarm is check for actually a ruptured balloon. So you look for your rusty flakes, look for blood in the tubing, and then always think that either the patient may have their head up too far if they're bent at the waist any, or you may need to kind of look at your catheter and make sure it's not kinked going in there, the insertion site, because that's probably the most common alarm you will get besides your augmentation being too low, and that's something that you can adjust.
All right. So speaking about, we're talking about the insertion site. Is there anything that you do when you go into a room prior to transport? Do you mark where that catheter or the line is going into the femoral artery? What are the chances of that getting pulled out or hooked on something? So can you talk about, number one, hooking the connections up? Do you hook them up really tightly? Do you hook them up just finger tight? And what happens if it gets pulled out a few centimeters? We've talked about, the placement, how big the balloons are now. What do crews do if that does happen?
Yeah, so as far as looking at the insertion site, I mainly look to see if, how the insertion site looks, if there's much bleeding going on, if it's clean, anything like that. Make sure the balloon's secured. Typically now it'll be sutured in, or there's some devices they've got that stick to the leg that hold it in. So I make sure it's secured somehow. And then you nailed it, the connections to the balloon, and if you use an extension tubing, that's something you want to look at. Make sure they're connected well, but you don't want to tape them together or over tighten them, because in our transport environment, it can happen. People trip things up, things get hung when you're going patients in and out of aircrafts or ambulances, and you can tug on that connection, tug on that balloon, and you try to guard it like crazy. But if you do, you want that connection to come undone at the pump or at that connectivity. You don't want it to tug on the actual catheter in the patient. So always be very cautious with that. Make sure you have slack. And then, I would say if you have those lines and you have connections in the helium line for the balloon, I always leave those, connected well, but I don't overdo it, because if I tug, I want that tug to come loose from the balloon pump itself, not from the patient.
Yeah, that would be a bad situation. Obviously, I think those are important points that, it's just like airway management. You don't want to lose that ET tube, and we guard against that. It's just taking a few seconds and making sure we do things the right way. We've talked about balloon rupture, migration. What are the incidents of retroperitoneal bleeding? That's something that you may not be able to see. So what are some clinical findings that may kind of lead you to identify that?
Yeah. As far as actual number, I don't know what the number is. And most of the time when you have retroperitoneal, it's done by the insertion. So when they're inserting it, that's the complications during that is what's going to cause the retroperitoneal. As far as signs and symptoms, of course, hemodynamic instability. You can have the Gray Turner sign, where you have bruising going up the flanks or ecchymosis going up the flanks. But with the patients, the biggest thing you're going to see is anytime you have what looks to be hemorrhagic shock from any patient that has been catheterized in their groin, whether it be for a cardiac cath or whether it be for a balloon pump or, just a sheath, whatever it is. One of the first things you want to think of is retroperitoneal bleed, and it is common to have that. So if you see that and it is diagnosed, your goal has got to be making sure and both taking care of volume replacement and hopefully with pack cells, and then trying to get them to clot. So one thing, if they have a balloon pump in and they're doing this, typically they're going to be heparinized, so that's fighting against you. You have to worry about it. And then another thing that's a common complication with balloon pump therapy is low platelets. So you have to worry about that. I used to have a friend that always told me, imagine Pac-Man going around eating up platelets, and that's what a balloon does the entire time it's in you. So you will have thrombocytopenia. You will drop your platelet count with balloon pump therapy. So that's something, common complication. So it can cause problems, especially if you have a retroperitoneal from the insertion of this. So kind of a double-edged sword if you get into that, but it does happen.
Yeah, I actually saw this happen one time, and I think that's why I bring it up. Obviously it's probably not as common. One of the things I remember, and we have to remember that, we talk about this in trauma all the time, that it takes 30 to 40% of your blood volume drop to even have a change in blood pressure. So, obviously with any transfer patient, I always preach, look at the labs, look at the H&H, identify what their H&H is from the start, know if you're behind already, know if you have already a depleted state. But you may not see clinical signs with a blood pressure, but you probably will start seeing clinical signs way before a blood pressure drop with your, your art line, pressures. And, if you do have the ability to look at those things, you'll probably see signs there before you'll see in a blood pressure. And, that's actually the nurse that I was with. She picked up on it. I had never seen it. She picked up on it before we ever saw clinical signs on a blood pressure. And let me tell you, he had a huge amount of blood loss, retroperitoneal-wise, that we, thank God she was had done a lot of balloon pump stuff, and so I think that's a really important teaching point.
Yeah, and the tough aspect of that is typically you are already dealing with a very sick patient
to
start with, and now you've got another complication there, and so many times you want to push those signs and symptoms you're seeing on the thing that is broke, and you miss that surprise thing, like that retroperitoneal bleed. But that is something you have to watch for.
Yeah. So let's talk about a console failure. This is something that's always tested on. It's always talked about. Is this something that's common? Does it happen? And can you talk about the difference between the Datascope balloon pump versus the new CardioSave, and how do you autofill each one?
Yeah, so that's always everyone's worst nightmare, and especially in transport is a failure. Typically in hospital, you have a failure. You've got somebody there in house or close by that can come in within that 30 minutes because you have a 30-minute window where it can sit still. So you do not want it to sit still any longer than 30 minutes. But if you can get someone to you within 15, 20 minutes to pull the balloon, that's ultimately what you want to do if you have a failure or if you can get to another console. But if you can, if it's going to be more than 30 minutes, if you're doing, we'll say a fixed wing transport that you're going 2 hours somewhere and it fails halfway there, then what you would do is manually inflate and deflate using a stopcock and a 60cc syringe. So you inflate and deflate based on the amount the balloon holds. Some recommendations are half of the amount, but you've got some dead space in there, and so you won't have that autofill property. So you're not going to be giving the full amount anyway. So if I've got a 40cc balloon, I'm going to push in 40 and pull out. I think the most important part in that is if you ever had to do this, is to make sure that you fully deflate it, then lock your stopcock, because what you don't want to do is leave a balloon halfway inflated in somebody, causing increased systemic vascular resistance, so causing that heart to work even harder, because they obviously would have a sick heart if they had this in. So I think that's one of the keys, is that you deflate it all the way and lock that stopcock off, and then 5 minutes later, inflate, deflate, lock it off. there is a process in the old the older data scopes like you talked about, and then the current 300 so forth, where you can draw helium out and use helium back and forth. In this type of setting, it's really not necessary. And in the cardio save that you mentioned, the newest one that McKay has out, it's actually not even an option, is my understanding, that you would just use air, go in and out, and then lock your stopcock off. The biggest thing, I think, is to make sure if you ever get in that setting, A, you're having a bad day. So so you deserve to go out afterwards. But B is to make sure that you're fully deflating it, and that balloon's not staying inflated, and that it's not staying immobile for anything more than 30 minutes initially and more than 5 minutes at a time after that.
So let's say you have a patient that's very, very unstable. Obviously, they're unstable enough to have a balloon pump. You have a failure like that. Now you're not getting augmentation. Or are there anything? I mean, obviously, you may have to start using a chemical balloon, being more aggressive there. But is there any recommendations regarding that?
Yeah, you're going to have to really go into your drug box and work on that, and try to figure out what's going to be the right thing for this patient according to what's going on with it. The thing to think about with these patients, most of the time, it's a cardiogenic shock. So in the cardiogenic shock side, you always know it's a pump problem. So what's going to give me some more squeeze? And then also, sometimes you have to cause some increase vascular tone, because you need it to also compensate. So you've got to look and try to balance those things out and see what's going to work best for you. Many times also you'll have ectopy, so you got those problems to deal with. The drug I always like to go to in these type of patients that were, low cardiac output, cardiogenic shock patients, was milrinone, was the drug I like to go to. Seemed to have less ectopy with it and a good increase in the actual heart function. And typically I could see a good cardiac output increase in that. With that, afterwards, making sure they had the right amount of volume and putting them on milrinone. Then you may also have to give something to tighten them up a little bit. Of course, you can always go to your epi that's going to do both and cause some increased contractility and stimulate alpha receptors also and cause some vasoconstriction. But then you really get into high risk of ectopy and also increasing your myocardial oxygen consumption and demand quite a bit.
So, to expand on that, can you kind of explain to the listeners, and I think this is a tough concept to understand, and you talked about vascular tone, you talked about, applying that squeeze. So you have a patient that's in cardiogenic shock. A lot of times they may have associated pulmonary edema. They've got a lot of back pressure against that mitral valve, and, they have maybe a mitral valve disease process. Kind of talk about, a cardiogenic shock patient, they're hypotensive, their SVR is through the roof, of applying a medication like milurone or dobutamine or even nitro, and how that, even though they're hypotensive and you're giving a medication that's going to cause a drop in blood pressure per kind of the literature, but how it kind of has an opposite effect in those patients.
Yeah, so, and that kind of brings up a good point about balloon pump therapy too. So anytime our patients become hypotensive, no matter what it's from, anytime there's poor perfusion, if it's from cardiogenic shock or whatever, one of the first things that is triggered as far as our bodies to respond is your baroreceptors. So your baroreceptors say, hey, you need to constrict up and tighten up a little bit. So your SVR, as you mentioned, is one of the first things that tightens up. So when we put a balloon pump in, many times, one thing that we can do is relax all that sympathetic system that's kicking in and saying, hey, I got to help him out. I got to help him out. I got to increase vascular tone. Got to do this. And it decreases that SVR and allows the balloon pump to work properly by kind of calling off that sympathetic nervous system by increasing perfusion. The same thing can happen with cardiac output. If I'm thinking of a pump and I've got a pump at my house and I want to get the pool emptied out, and I've got a 2-inch hose and a 4-inch hose, I know that pump's going to work a lot less hard and be able to move more volume through that 4-inch hose. If I put that 2-inch hose in, we think of the pressure going through, it's going to be a high pressure, low volume. If we put the 4-inch pipe on, low pressure, high volume. So as far as workload on that pump, it's going to be a lot easier for it to work because less resistance in that 4-inch pipe. And that's what's going on with your SVR. And so sometimes when you have patients that don't have great heart function, and you look at that patient and their SVR, everything's tightened up on them, something is stimulated their sympathetic nervous system to tighten them up. Many times you can throw a little bit of nitro at them and vasodilate them, and their heart function actually improve, their cardiac output improve, and you can see the patient improve. Milrinone and dobutamine both work the same way in the fact they increase contractility, but they also vasodilate, and many times you will see a 10-point drop in your systolic blood pressure when you start either one of them. The key is that you have the right amount of volume there, and then when the heart function picks up, your pressure and your perfusion, your body's perfusion is going to increase, even though your pressures are down a little bit, because your heart is working and functioning better. So that's how that works. Many times we would have patients come back from surgery, bypass surgery, and have swans in where we could see, CCO swans. We could see everything that was going on and fine tune everything and watch that SVR. And it was not uncommon at all to see a patient with a cardiac index of 2.1, 2.2, and a systolic blood pressure of 88. And we throw some nitro on, and that cardiac index pop up to 2.8, and then all of a sudden you see a systolic of 110 with a little bit of volume and nitro.
And I think that is a hard concept because we've pounded in, obviously beginning as a paramedic, you're always told watch that systolic, and it goes against everything you're taught. But again, that's where critical care comes in, and you look at things from a global perspective and understand that that's not always what's going on. Obviously, these patients have a stunned left ventricle, whether it's a dilated cardiomyopathy or that's probably the most common. And if it has all that excessive pressure, if it's already weak and it can't pump effectively and it's under all that pressure, those medications are perfect. And I think I really appreciate you kind of explaining it in that way. I think that's a question that's constantly asked, and I seem to have to spend a little bit more time with people on that concept because it's not intuitive. It goes against what you would think would happen.
It's tough to see, and that's one thing that I really appreciated my time of dealing in a cardiac ICU and dealing with those patients, because until you're able to see all of those numbers and fine tune those numbers, it's hard to realize that when you're dealing with a blood pressure cuff and an ECG monitor. It's very hard to appreciate and see everything that goes in and all the numbers and where every valve is and where every stop point is, and to see how you can manipulate that with different drugs and improve that function.
Well, very, very cool, man. Well, hey, this has been a great podcast. I know we've gone a lot longer than normal, but I think we've covered a lot of really great information. Again, I'm really, really excited that Kelly was able to spend some time. I know he's as busy or busier than I am, and this is 10 o'clock at night for him, so I know he's taking time away from his family. I want to let him get back to his wife and kids, and hopefully his kids are in bed. I know he's got younger kids, but so we'll wrap this up. If you ever have any questions, I will put Kelly's email address on the show notes. If you have any questions, you can email him, if that's all right, Kelly.
Yep, that's fine.
And like I said, we will get a blog post in shortly after the release of this podcast, and I will put a few links in the show notes where people can access some information. And again, I want to thank you for joining us, and we'll have you on again, and really appreciate your time.
Really enjoyed it. Appreciate you having me on.
All right, guys. Well, like I always say, I appreciate all you do. We know that we're nothing without you, and then just continue all the nice emails and any ideas for podcasts. We love those ideas. We want to do what you guys are seeing out in the field and what will benefit you. So as always, just feel free to call me or contact me via email. And until next time, we'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.